Buenos días, muchas gracias por estar acá, bienvenidos nuevamente a este segundo día de congreso después de la plenaria que tuvimos tan interesante sobre vasculitis. Pues vamos a cambiar de tercio y ahora vamos a dedicarnos a la esclerosis sistémica. Es un tema en el que en Medellín especialmente le hemos tenido mucho cariño con varios doctores de nuestra ciudad y que se han venido conformando equipos de trabajo multidisciplinario entre reumatología, neumología, cardiología y radiología, de la mano de algunos de los compañeros que van a exponer y que también queríamos tener entre nosotros a la doctora Janet Pope, que viene de Canadá, porque ella le tiene bastante cariño a nuestra ciudad, es una experta en este tema también, y queríamos tenerla con nosotros y gracias a la doctora que está aquí, es la doctora Janet Pope, es profesora de medicina en la Western University en Canadá y ella quería que la presentáramos de esta manera, as a researcher, as a teacher and as a clinician. So welcome, Dr. Pope, thank you for being here with us and you're going to open this lecture. We are so happy to have you here. ¿Es el de arriba o el de abajo para pasar? No. Okay, he's going to agüita. ¿Y tienen un mouse o algo para señalar?
Good.
Okay, you have to push that.
Good. Okay, great. Thank you. Thank you, everyone, for coming. It's very unusual to have a full room with people in the front row. Good for you, Colombian Rheumatology Association. It's very good. I put my Twitter name on because I think I have a lot of Spanish trainees and young rheumatologists following. And I guess when you see the pictures of my patients, you think I don't give very good care. But I try to give good care, just to know. It's also 10 years from when I was here at your organization last, right here. So I feel very privileged to be back. I'm going to talk very briefly about Raynaud's and digital ulcers really in systemic sclerosis. So you had given me a title with a little bit of a pun, so handy treatment tips for Raynaud's and digital ulcers. These are my disclosures. And I want to talk a little bit about when we diagnose Raynaud's, whether it's idiopathic or primary, compared to secondary, and how we should make the diagnosis, and really to look at the treatment of Raynaud's and digital ulcers. So very practical. So this is one of my patients, very obvious to see the pallor, the whiteness. You can see the other finger has some cyanosis, and you can look very carefully on the other hand and see some telangiectasia, and on her palm. So this is a patient with Raynaud's and scleroderma. When we talk about it, I think it's important that we see pallor, whiteness, ischemia, not just erythema or cyanosis. Because many of us, if I sent you to Canada today, you might be a little bit purple at your fingertips because it's -10 there today. So basically, I think it's important to differentiate Raynaud's from just a normal reaction in the cold where we'll vasoconstrict a bit. So pallor and one of two more, erythema, cyanosis, or all of it. So we're going to vote with our hands raising. So if they're in another room, I won't know how they're voting, but you can vote more than once if you're not sure. But how common is Raynaud's in Colombia? So who says Raynaud's phenomena is 25% of your population? Okay. Who says 10%? Okay. Who says 1 to 5%? Okay. And who says really, really rare? Okay. So we have a range of what you're thinking, and by self-report, now everyone can take a picture of their hands. So by self-report, Raynaud's is about 1 in 10 people in the general population. But if you really take a better history or they show you pictures, It's about 3% of the population. And the warmer you are, the closer to the equator, it might be closer to 1 or 2%. But, you know, when we see people in clinic, we see way more Raynaud's than that. In rheumatoid arthritis, 1 in 10 to 1 in 4 people have Raynaud's, and we don't even always ask them about it. Connective tissue disease, higher rates. So it's a few percent of the population, more complained about and more prevalent in a colder country like Canada. And on the other side, if we think someone has systemic sclerosis, if they don't have Raynaud's, think again. We might not have the right diagnosis. So almost everyone with systemic sclerosis has Raynaud's, but the general population, probably in Colombia, 1 to 5%. And when we're talking about Raynaud's, we divide it either as primary or what you call idiopathic, not associated with another disease, or secondary. And it's usually secondary to a chronic disease, such as for us, connective tissue disease. Could be from Takayasu's arteritis. It could be from Berger's disease, thromboangiitis obliterans. When people have had injury like jackhammer, vibration injury, it's difficult to know, are they primary with a cause or are they moving towards secondary Raynaud's? And I don't really know what to tell you. I'm not exactly sure whether they're sort of primary and a half. They're closer to more severe Raynaud's, but they're not like our scleroderma patients with digital ulcers. So in this study, this is from Michigan, from United States, cold like Canada. General population was about 3%, but if you have a patient with Raynaud's, in their family, it's about 1 in 10, 10%. And some of you were guessing around 10%, and that might be why. If someone has Raynaud's, it's higher in the family. Also in systemic sclerosis, where 95, 99, 99.5% have Raynaud's. In their family, primary or idiopathic Raynaud's is about 1 in 10 as well. So we do get referrals where a patient with scleroderma will say, you know, my child has, or my adult child, or my sibling has Raynaud's, are they going to get scleroderma? So Raynaud's can manifest in a scleroderma first-degree relative more than what you would expect. Just like ANAs are more common in a relative of someone with lupus than in the general population. Same idea, some of these features can cluster. When we're thinking of is it Raynaud's or not, I don't think complex regional pain looks like Raynaud's, but you can have puffy fingers, vasomotor instability, you can have mottled skin, different sweating. I think it's different than Raynaud's if you take a picture of what's going on when the patient has the attacks. Acrocyanosis is just a fancy word for distal blue fingertips. Some young women, skinny people might get it more than bigger people, as a for instance. Just a regular exaggerated cold response. Obviously peripheral vascular disease, so if someone has poor blood flow to an area, they usually have ischemia for sure, if it's critical low blood flow, but they don't always have pallor. They're often erythematous, cyanotic, and cold. And certainly Berger's disease or thromboangiitis obliterans is obstruction of the blood vessels. They're tapering in your digits of your hands or your feet or elsewhere, but usually they don't have the pallor, but they can have, but usually they don't. They're usually cold, they're getting a gangrenous ulcer, they're blue, but they're usually not pallor, but they could be. And then you can look with your naked eye and see things like the dilated capillaries at that periungual area. So if you see that, we're thinking it's secondary Raynaud's. Puffy fingers, you're thinking secondary Raynaud's. Different from dactylitis of psoriatic arthritis because it's involving all the fingers, all 10. Thinking of, do we see telangiectasia, lips, hands, chest, mouth, elsewhere? Do we see calcinosis? So tips to think of secondary. So now most of the treatment for Raynaud's is in secondary Raynaud's phenomena. So we think of the vascular changes in systemic sclerosis from vasospasm that's inappropriate to full obliteration of the blood vessels. So we'll do another vote because there's more than one right answer here, so you can vote, don't worry. If a patient has Raynaud's and we know that they have anti-centromere antibody positive or their ANA pattern is a centromere pattern, what's the chance of getting systemic sclerosis over the next 5 years? So who says 1%? Who says 10%? Who says 30%? Okay, who says 50%? Yeah, so you're going mostly 30 and 50, and I'm giving you a little bit of a hint there. So it depends on the study, and U-star VDOS, the very early systemic sclerosis, about 1 in 3 people with Raynaud's and a centromere antibody will develop systemic sclerosis over the next 3 to 5 years. In some clinics, if you have more things, you have maybe dilated capillaries, you have a centromere ANA, and you have Raynaud's, you're already further on the spectrum. Or if you have dysphagia as well, we'd say, well, you probably have scleroderma, even if you don't meet classification criteria. But about 1 in 3, if the patient's asked, that's the number I give them. Okay, so you're more apt to have Raynaud's with a connective tissue disease if you have a positive ANA, strongly positive, but more specific patterns like centromere. But also nucleolar is a pattern that seems to cluster with our diffuse scleroderma patients. If you have nail-fold capillaries that are already abnormal, so the blood vessels are not just reversible spasm, they're changing. And that up to 30%, there is a reference there. That's an old one, but VDOS is about the same. So again, thinking about these sort of factors. So when I see a person with Raynaud's, do I do an ANA and a complete blood count and a urine? No. If it sounds like it's primary, don't look hard. You're going to do a history and a physical because you will find that positive ANA and you'll be stuck with that, seeing them annually for years, because we have to remember anti-nuclear antibodies are strongly positive in the general population. So we're going to shift to talk about treatment of Raynaud's and then digital ulcers. So primary idiopathic Raynaud's, only rarely would they need drug treatment. So keeping warm, a hat because you lose heat on your head, mitts are better than gloves, putting your fingers together is better, warmer, warm footwear, not having your coat wide open on a rainy, cool day here, or if you go to Bogota where I think it's always a bit colder than here, it's so high up. So you gotta have people try to keep warm. You want them to stop smoking because that can have more vasoconstriction. Then if you're going to move on to therapy, most therapy is in secondary Raynaud's. Primary often doesn't need it, but it'd be calcium channel blockers. We'll look at the data. The data are pretty crappy, but we'll look at it. And then other drugs, topical nitrates, PDE5 inhibitors. Angiotensin II inhibitors like losartan, in my opinion, are a waste of time. I never see them work almost. SSRIs, one study on fluoxetine, I've never seen it work, although there is some positive data. Prostacyclins, can you get intravenous iloprost here, prostacyclin? Are you guys able to get it here? Yeah, good, because it's difficult to get in North America, but we can get it in, by special access because there is no drug number for it. Unfortunately, we'll see some trials in iloprost that won't look as good as we would like, that will come out in the near future because of COVID. The trials look positive, 2 big United States trials, one positive, the phase 3, to try to get the drug into the US, positive until COVID hit, and then it was not positive anymore, which is unfortunate because people were stressed out with COVID. People dropped out of the study, lots of reasons. But anyway, in my opinion, and in old data, prostacyclins work. Alpha blockers usually aren't tolerated, but that would be like prazosin is one of them. And ACE inhibitors don't work in secondary. There's one study of quinapril, which is like captopril, that has some positive data in idiopathic Raynaud's. I've never seen an ACE inhibitor work in scleroderma for Raynaud's. So what can I expect if I'm going to give a prescription to my patients for treating the Raynaud's? If I'm going to give a drug prescription like nifedipine, what can I expect? Not a lot. So for calcium channel blockers, you say, if it's relevant to you, you might decrease your number of Raynaud's attacks by 1/3. So if you get 10 attacks a week, you might get 3 or 4. That could be clinically relevant. But if you get 10 attacks a day and you go down to 3 attacks a day, I think you're pretty happy, relatively speaking. Often the severity of attacks, how bad are they, and the duration of attacks, how long do they last, are no better on a calcium channel blocker than placebo, but you can get more benefit if you increase the dose. And side effects are common. We now only have nifedipine long-acting 30 milligrams in Canada. We don't have 10, we don't have 20, and we don't have short-acting at all. So 30 milligrams long-acting for nifedipine. And I might go 30, 60, 90 if you have really bad Raynaud's and you tolerate it. Lightheaded, puffy legs, flushing, a headache, things like that from hypotension and vasodilatation. So this is one of the systematic reviews that we've done, but the bottom line is if you said, how is your pain on Raynaud's, and say the average pain is 7 to go into trial, maybe 6 out of 10, you'll decrease that by about 2 points, by about 1.7, which by the way, for a patient on average is clinically relevant. So getting a pain scale down by 1.5 to 2 points out of 10 is relevant for patients. And then what about the reduction in the frequency of attacks? Not all calcium channel blockers are created equally. So verapamil, waste of time. Diltiazem, not great. So we're looking at that group, the dihydropyridines. So you have nifedipine, you have amlodipine, you might have felodipine, and you might have some other ones in that class. That's the class because it's very good on distal peripheral blood vessels. Verapamil is supposed to be very heart selective, cardioselective. It's not fully cardioselective because it gives people diarrhea. So it's doing something elsewhere, but it's not good distally. The prostacyclin, so some of you will and do get access to it. So there's 5 randomized controlled trials and 2 more to come from the US that aren't published yet. It is effective, iloprost. It can decrease the frequency and the severity of Raynaud's attacks. They're almost all done in severe Raynaud's, secondary Raynaud's, usually secondary to systemic sclerosis. And again, if we look at the digital ulcer data, it wasn't a digital ulcer study. So if you combine all these randomized controlled trials, Fred Wigley and others that did them, you can decrease ulcers, new ones, but you can get better wound healing for ulcers. So in my opinion, vasodilators help you improve your healing of ulcers, but we don't have very good data on that either. So our algorithm for Raynaud's is basically you want to, if it's bad enough, you treat, so smoking cessation, keeping warm, good common sense, avoid stress, as though any of our patients can easily avoid stress. But basically, calcium channel blockers, nifedipine, increase the dose if needed, switch to a different dipyridine if it's not severe Raynaud's. If it's more severe, go to a PDE5 inhibitor, which we'll talk about, so sildenafil or tadalafil. If not, move on to IV iloprost, and sometimes if you can't get a PDE5, you'll move iloprost upward. Ustar and Ular say the same thing, so think of a nifedipine first, if it's bad enough, iloprost, and then or PDE5 inhibitors. PDE5 can come topically as well, but if you have 4 fingers there and 2 here, you're probably not going to do topical, you'll do oral. So complication of Raynaud's, severe ischemia, which can be acute or subacute, digital ulcers, infection, surgical need for amputation for dead tissue that won't come back, or auto amputation, which is very painful as the patient's waiting to basically drop their fingertips off. You can get pits and you can get tuft resorption. Tuft resorption can be quite painful when you have no padding for texting, for doing typing, for doing your activities of daily living. So if someone has gangrene, it's black or dark, to me that's an emergency. I will optimize calcium channel blockers, but basically move on to either prostacyclin intravenous, so iloprost, even epoprostenol or treprostinol, or I'll move on to PDE5 inhibitors. Are you able to get PDE5 inhibitors easily for your patients who can get it? Because so some can, but it's difficult, it's expensive. So we now in Canada are able to get them under special access for severe Raynaud, such as scleroderma patients. And that will make a big difference for our patients. And don't forget that these patients have pain, so pain control, and don't treat with antibiotics, topical or oral, unless if they have an infection. Topical antibacterials can be a barrier, which gives a bit of pain relief, but these people have pain, maybe ring blocks, maybe sympathetic block, if you can get them to someone to do it, or maybe giving them good analgesics, because if you have a sore finger, you know how much it hurts. If you have gangrene, it really hurts. So a couple things in digital ulcers. So on any day, 1 in 6 scleroderma patients has a finger ulcer, 15%. It's not always fingertip. You can have an ulcer because you have a flexed hand and you get wounds because you have no coverage there over your knuckles. But 15% of our patients on any day have an ulcer. And like the bigger picture there, they're often more than one. The mean number of ulcers coming into clinic, if you have one, is 2.3. So some people have one ulcer, but the biggest chance of ulcers are ulcers. So some people have 2 or 3 or 4. The other thing is ulcers ever in scleroderma are half our patients, 50%. But on any day, 15%. And then ulcers can be mild, moderate, or severe. So you can see in this patient, she's got 1 on a thumb, she has 2 on the other hand, some are very large and extremely painful, and one of these got infected, and in one she needed to amputate, we needed an amputation. The other clinical pearl that's important is that if someone comes to you, even if it's scleroderma and you know it, if they have mostly feet ulcers on their toes, and hardly ever or never on their fingers, think peripheral vascular disease, because that might be treatable. So I get them to a vascular person, we get an angiogram, maybe they can have an angioplasty. So if it's only in their feet or mostly in their feet, they probably have peripheral vascular disease. That's an important clinical pearl. Digital ulcers, this is my sort of menu, but it's not very good data. So if you do something different, you're as good as I am on our data. So calcium channel blockers have weak data for nifedipine, intravenous prostacyclin or PDE5 inhibitors, sildenafil, or tadalafil if you can't get sildenafil. Prevention, does anyone get bosentan here for prevention of ulcers? Okay, so some people do. We can't get it in North America for this indication. In Europe, it's about 1/3 of bosentan use is for digital ulcer prevention. Endothelin receptor blockers do not heal ulcers and basically do not treat Raynaud's. So there's one study with a slight effect on Raynaud's, but all the other studies, including the digital ulcer studies, no effect on Raynaud's. And then there's one study, and I can get atorvastatin Lipitor, it's inexpensive, fully off-label, 40 milligrams of atorvastatin, single-site study from Turkey, decreased new ulcers by 50%. So why not? I give aspirin, a baby aspirin, why not? I don't give anticoagulation unless if there's a proven clot. Current management would be treating infection, treating pain, preventing ulcers, a team approach where someone can give blocks for you to help the pain, where someone can debride ulcers. I don't have a big team approach, so I can give a short-term block. I certainly don't know how to give a sympathetic block. So there's different treatment in different scleroderma centers. So this is from Chris Denton, this slide. He gave it to me. So first of all, most Raynaud's that is the general population is idiopathic or primary. Only investigate Raynaud's if you suspect secondary, or you'll be stuck with a positive ANA that's irrelevant. Secondary Raynaud's is very common and more severe in our population, and we have treatment from calcium channel blockers, nifedipine, to looking at PDE5 or prostacyclins. Beyond that, stellate ganglion block, surgical management, and a lot of made-up things. I didn't mention Botox. There's no randomized trials, some case series that are positive, some that are negative, no standardized treatment, but the idea is you won't get vasospasm of the proximal digital arteries. If you're going to give topical, except for here for pain, topical should be down here at the web space because that's where your artery is the widest. So with that, I thank you, and I always thank the funders, and I thank our patients that so graciously let me do research on them. So thank you very much.